So I'd now like to introduce Tomasz Klupa, who's going to talk about some glucokinase MODY patients, and again to illustrate the learning points from these cases. Thanks very much.
Okay, thank you. Well, I must admit that we don't have such interesting stories to tell about our GCK MODY patients. They're quite homogeneous. So I decided to somehow concentrate on their treatment, which is not clearly defined. What should we do with our patients? So I will start with a short introduction. Then I will give you some insights into our short intervention study concerning diet in the GCK MODY. And then I will show you finally the case of severe GCK MODY patient. As it was mentioned earlier, GCK MODY is an autosomal dominant form of diabetes caused by mutations in GCK glucokinase gene encoding a key regulatory enzyme of pancreatic beta cells. GCK mutations increase the threshold for glucose-stimulated insulin secretion, resulting in a mild form of diabetes. Typical clinical features related to GCK MODY include fasting hyperglycemia above 5.5 millimolar per liter. HbA1c typically is just above the upper limit of normal range, rarely exceeds 7.5, but I will show you cases with higher HbA1c levels. In an OGTT, the increment is usually small, less than 3 millimolar per liter. As it was also mentioned before, family history may be misleading. I mean, it's usually such a mild form of diabetes that family history may be simply false negative. So now I would like to switch to our short intervention study concerning this issue of GCK MODY treatment. Since usage of oral hypoglycemic agents or insulin rarely changes HbA1c, nutritional intervention remains the treatment of choice for this form of diabetes. The diet formula most effective in reducing glycemias for GCK MODY remains, however, to be established. So we try to evaluate the impact of carbohydrate content on glycemic patterns among GCK mutation carriers. We exposed 10 GCK mutation carriers, 7 with diabetes and 3 with impaired fasting glucose, to diet rich in carbohydrates, approximately 60% of calories coming from carbs for 2 days. Then we switched them to low-carb diet with only about 25% of calories coming from carbs. We evaluated glucose levels with continuous glucose monitoring. This is the clinical characteristics of our mutation carriers, and as you can see, HbA1c level range from 6.1 through 8.4. So we also included individuals with relatively high HbA1c level. And also look at the BMI. The BMI ranged from 21.1 through 30.2. So our group included overweight and obese individuals, all were treated with diet only. Oops. Okay. These are the results of our study. So on hard carb diet, the glycemias tended to be higher in general. They were more variable, and they tended to cross the line of 200 milligrams per deciliter, while on low-carb diet, the glycemias looked like in a healthy individual. The fasting glycemia was just shifted a little bit up. So we concluded that postprandial hyperglycemia is observed on a high-carb diet in GCK MODY patients. A diet with modestly limited carbohydrate intake may be effective in optimizing metabolic control in GCK MODY. Carbohydrate restriction seems to have no major impact on glycemias in GCK MODY carriers not meeting the formal criteria of diagnosis of diabetes. To our surprise, the best therapeutic response to diet was seen in overweight or obese individuals with GCK MODY. And now I'd like to present the case of father's son. Father was diagnosed at the age of 23, clinically diagnosed. His current age is 49, current HbA1c is 7.4, and his current BMI is 30.2 kilograms per square meter. His son was diagnosed at the age of 12, his current age is 18, HbA1c is 7.3, and his BMI is 28.4 kilos per square meter. As far as glycemic profiles are concerned, the fasting glycemia ranged between 131 and 149. Now, the postprandial glycemia was up to 200 milligrams per deciliter on regular diet and up to 169 on low-carb diet. Unfortunately, the long-term compliance to both low-carb diet and calorie-restricted diet was very low. So now I would like to invite you to the discussion, what are the therapeutic options for those individuals? Should we just leave them alone with HbA1c level of about 7.3 through 7.4, or should we implement some sort of treatment? Do you have any ideas what to do with them? Definitely the easiest thing to see would be to implement physical exercise and to implement calorie-restricted diet, but it's easier to say, it's very hard to implement it in real life. And knowing those patients, we would not expect this form of intervention to be too effective. Especially if you take patients' dietary history, if you look at what they eat, how much they eat, and if you listen to them that they describe their meals with such a pleasure in their voices that it's almost not possible to do. Another option is to put them on metformin, and this metformin may, on one hand, may have the goal of optimizing glycemias in those individuals. They present with obesity, they are overweight, so probably they present some form of insulin resistance. On the other hand, it may be sort of prevention of development of type 2 diabetes. As we mentioned previously during the lectures and discussions, some GCK MODY patients may develop later on type 2 diabetes. Actually, we don't have the good answer for this question. And now I would like to switch to another carrier of GCK mutation. She's a very lean lady, 52-year-old, diagnosed at the age of 40. She's a G2R mutation carrier at the codon 261. He has a typical positive family history. When we saw her for the last time, she was on metformin 1.5 gram per day, on acarbose 300 milligrams per day. Her glycemic profile was as follows: fasting up to 160 milligrams per deciliter, postprandial up to 200 milligrams per deciliter, and she observed some deterioration of glycemic control after operation due to femur fracture. Her current HbA1c level is not that bad. In the past, however, it was up to 7.9, and she reported even higher levels of HbA1c. What's important, patient is diagnosed with osteoporosis. Currently she is treated with calcium, vitamin D, and we were considering biphosphates in this case. Her BMI is 21.6. She is very careful with diet. Her diet is characterized by low calorie and carbohydrate intake. So as far as diet is concerned, she has no reserves. We do suspect that her osteoporosis is at least partially due to malnutrition, to this low food intake. Her lipid profile is as follows on statin of 20 milligrams per deciliter, and her blood pressure is maximally 165 over 95, and she is currently treated with perindopril. And we also had the dilemma what to do with her. Definitely we wanted to withdraw both metformin and acarbose. Again, she's a lean individual.